Each one of the faculty today can actually speak on any of the topics, and we are all very happy, that the physicians are all from this tri-state area. So most of you would have identified one or other of the speaker as your physicians too. So just to bring you together with your physician to learn about myeloma. And it also shows that we all collaborate in this arena to find a cure for myeloma. With that background, I'd like to now introduce our first speaker, Dr. David Wiesel, who's the co-chief and director of research for multiple myeloma at John Thurer Cancer Center. But a word, David and I go a long ways. We were together at University of Arkansas. He was my first faculty recruit there. And we have also been together in New York, so it's always a pleasure for me to introduce David. But he's also an excellent speaker, keeps it lively, unlike me. Thank you.
Thank you, Sundar. It's really a pleasure to be here. What a crowd. This is fantastic. Normally the person who gives the first talk is the oldest because they've had the most experience giving the most, basic talk. And I want you to know I'm not the oldest. He is. So I don't know how that got screwed up, but he is the moderator for the program, so I guess he's still got that above me. So I have the pleasure of talking to you about basic myeloma. And as Sundar said, I like to think of my care of all of you as a journey, just as you think it's a journey that going the pathway from diagnosis through the course of your lives. My journeys are a little bit different because my journeys, when I'm not taking care of my patients, is to travel whenever I can. So you're going to see some of my travel pictures. This is really a sad day in Yankee times because Derek's no longer there. I mean, who really cares? Who's watching the Yankees anymore, right? So Alex Rodriguez started off okay, but he's fallen by the wayside. Must be something he's taking. Anyway, patients comes to my office, and these are the questions that are posed to me. And this is, I'm sure all of you have done the same thing, either all of them or some of them, when you first got diagnosed with this disease. First of all, almost none of you probably ever heard of this thing in your lives. Second of all, if you had, you probably didn't know anyone else that had it. And you want to know, well, what is this thing? The doctor says they have bone cancer, not bone cancer, the typical thing. Bone marrow cancer is the right term because it's a malignancy of the bone marrow. And no one's ever knows what it is, and it's a rare cancer, as we're going to see a little bit. It's only 1% of all the cancers. 1% of all the cancers, so it's not unlikely that you've never heard of it. It's not like lung cancer where there's 200-some thousand cases, and breast cancer. Everyone hears of those things. No one knows about myeloma. So the first question they always ask is, what is it? And we try to explain that to them. Second question is, why? And with a few exceptions, few diseases, mainly related to smoking, most of us haven't got a clue why anyone gets any malignancies. And we can't really tell you why. We're trying to find out the whys in different researches, but we can't tell you why. We can tell you that you have it. We can tell you that there's no definitive relationship. And we're going to talk about all these topics in my talk. This is a preview of my presentation. Then the question is, well, how bad is it? And what I interpret that means what stage it is. A few that are brave will say, well, what does that mean? And how long am I going to live? Which none of us can ever say for sure because none of us have crystal balls. So some of you actually want to know that, and others go like they don't want to know. It's all such a shock anyway, let alone to be told you've got a death sentence hanging over you. Because most people, when they've read anything before they come and see us, everything says incurable, incurable, incurable. We kind of think of it as chronic, 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 not incurable. But that's not what you guys come in to talk to us about. You say it's incurable. Well, how long am I going to live? Then they want to know is, what about my family members? What about my kids? What about my brothers and sisters? Are they at risk for getting this disease as well? And people are shaking their heads out there. If you haven't thought about this, you should, because these are things I would ask. And then they want to know, well, what are you going to do about it? And how sick is it going to make me? And I'm actually going to talk about that part. My colleagues are. So first of all, what is myeloma? It's a malignancy of the bone marrow. All of us have plasma cells in our bone marrow. Plasma cells are good cells. Plasma cells make antibodies when you get infected. We want to have plasma cells. What we don't want them to do is become malignant, because when they're malignant, these same plasma cells that normally make antibodies, but they're not anti-infection. So for example, you have strep in your throat. There's a whole cascade of immune events that happens, and ultimately that strep infection through the immune system stimulates the bone marrow plasma cells to make anti-strep antibodies. That's a good thing. But when you have myeloma, these plasma cells, which we now call myeloma cells, make antibodies, but there's no strep infection that caused them. And we can measure those antibodies in the blood or the urine. And that's how we can tell how well you do. And most of you have had this disease for a while. You know that when you get treated, that M protein or monoclonal protein or S-PEP result, whatever you think in your mind of how you follow the disease, when the treatment works, it goes down. And we know we're killing the cells because we have less antibody that we can measure. Unfortunately, the immune system gets all screwed up because of this, and it doesn't make normal antibodies. So you make these antibodies that don't have any function, you don't make normal antibodies, so your immune system doesn't function very well. So then everyone goes like, especially if they've had a transplant or not a transplant, they go, well, what about my immune system? And I'm going like, okay, well, first of all, we think you had myeloma for 15 years, 10 to 15 years, we think it percolates before we actually diagnose you. And your immune system's probably been shot for 10 to 15 years before that, and you never worried about it before. So yes, your immune system's compromised, and yes, we get concerned. And most of my colleagues, you come in with a little cough or something like that, we're going to give you an antibiotic right away, which is kind of like not what you're supposed to do in general practice. But your patients have a compromised immune system, so we're jumping to give you antibiotics. But this is not a new phenomenon. You've had a compromised immune system for years before you even got treated. Looking at it in a different way, this is kind of a cartoon picture. We have our bones, and the cells live in the bone marrow, and they make the antibodies, and that little blurb on the side is, let me make sure I get the thing. This is what the antibody molecule looks like, and there's two different parts of this. I'm going to show you a blow-up of this in a second. There's two different parts of this antibody molecule, or immunoglobulin, a heavy chain, and the little blurbs on the side are the light chains. And we can measure both of those in the clinic. So so some people say, well, what kind of myeloma do I have? I didn't put that on my list of questions because most of you don't even know what myeloma is, let alone what type. But once you've been diagnosed, you go like, I've got an IgG kappa, and that's what we follow. Well, the IgG is the heavy part of the molecule, the big long ones with the 30-degree angle, and the smaller little bits are the light chains. So the heavy chains come in 5 flavors, and the light chains, the smaller pieces, come in 2 flavors. That's the eye color of your myeloma. It doesn't change over the course of your treatment. So if you have an IgG kappa, you stay in IgG kappa. If you have an IgA lambda, you stay in IgA lambda. It's just the eye color. As it turns out, it probably doesn't matter what color your eyes are. Everyone comes out about the same. But that's how we designate you when we look at it. So we talked about this briefly. Myeloma is not common. When you look at all blood cancers, not all cancers, myeloma is about 20% of all blood cancers. It says 17%. So everyone's heard of lymphoma. Everyone knows about Hodgkin's disease or Hodgkin's lymphoma, even though it's a very small, if you look at this part of the pie, Hodgkin's lymphoma is actually very rare. It's only 4% of all blood cancers, but everyone knows it because it affects young people. No one knows about myeloma, even though it's actually the second most common hematologic malignancy after lymphoma. So this is one of my trips. This is kind of an old picture. If people have heard me before, you've seen some of my pictures. We have a few new ones in here. I'm not going to torture anyone today because I don't have enough time. This is Petra. So this is old. This is not a building. This is a carving. If you look at this, this is a mountainside. Oops, excuse me. This is a mountainside, and they carved the building into the mountain. That's what Petra looks like. And for those of you who remember Raiders of the Lost Ark, one of the Raiders of the Lost Ark ended up at this spot. So Petra's really cool. It's in Jordan. It's almost impossible to get there. I show this because myeloma is an old disease. There are thoughts, it's hard to prove, that mummies, that they can find out that even mummies had myeloma. This is a CT scan of a mummy. This is a backbone, and they see these spots in the vertebral bodies that they think might have been myeloma that they found in this mummy. Well, the first cases, this is me in Winston. Yeah, that was last year at a Waldenstrom's meeting, which is a cousin disease of myeloma in London. But the reason I show Winston here, because Winston was a very bright guy, but so were the Brits. And the Brits were actually the first people to describe myeloma, as it turns out. In 1844, a first case, young lady, because she was only 39, named Sarah Newberry, was thought to be the first documented published case of myeloma. And at that time, and I don't show the picture, it's rather gruesome, because at that time they had no good photography. They would have everything hand-drawn, and there's these pictures or cartoons of all her broken bones with a picture of her face in it. They're just as gruesome, because she broke a bunch of her bones. And her autopsy, because back up until the 1920s, everything in medicine was really based on autopsy findings. And they found this glop in all her bones that was, as now we think, was probably myeloma. We didn't actually have the term myeloma until 1873, and actually it wasn't until 1929 that people first were subjected to bone marrow biopsies, which I'm sure you all love. So there's about 27,000 cases of myeloma diagnosed every year. They're increasing by 1,500 to 2,000 cases every year, 1,500 to 2,000 cases every year. So if I give this talk next year to you, the number is going to be about 28,000 or 29,000. Why is that? It's not an epidemic. Our population is aging. Baby boomers, 1947 to 1964, are all approaching 70, which is the average age for this disease. So we have this big oomph of the population hitting that period of 70-year-olds, and that's the group of individuals who are more prone to getting this disease. So the number of cases keeps rising proportionally to the aging of our population. There's about 80,000 individuals who have myeloma in the US. The incidence of males over females is slightly higher. It's about 55 to 45, and as I already told you before, it's a very uncommon malignancy. So sometimes we have to put our hats on and go visit Sherlock Holmes at 221B Baker Street and try to come up with some solutions of why you get this disease. So we asked Sherlock. He came up with risk factors for us, and you know what? He didn't do a very good job, because there's a whole list of things that are possible associate causes of myeloma, but there's none that are definitive, with the exception of these two right here. The government, our government, recognizes Vietnam vets who are exposed to Agent Orange, and our government recognizes individuals who had extensive exposure during 9/11 as having a slightly higher incidence of getting myeloma. Outside of those two groups, I haven't got a clue what really causes myeloma. Well, one of the other questions we pose is, what about families? Well, in Sweden, actually one of the researchers originally from Sweden, who's now at Sloan Kettering, down across the way a little bit, named Ola Lengren, actually did a study in Sweden, because they had a fantastic database of the whole country's health status. And he was asking the question, does this really run in families? And the easy way to answer that is essentially no. But I say essentially, not no. There's a very, very small risk of having another family member develop myeloma if they have a list of other types of problems with their immune system, which I've abbreviated here, MGUS, which we're going to talk about. If they have Waldenstrom's, which is a form of lymphoma, if they have chronic lymphocytic leukemia, if you have any of these types of malignancies, or if you have myeloma, you have a slightly increased risk of developing myeloma in another person in the family. But it's extraordinarily low. We do not screen family members. There's no reason to do that. You should tell your families that the answer is essentially no. You don't have to worry about it. We do not have an inherited gene. All of you keep hearing, because Angelina Jolie was just in the publicity again because she's got this BRCA gene for her breast cancer. Her whole family has breast cancer. She has a gene that's inherited. There's no known gene in myeloma that we know at this point in time that's inherited. So what is the bad guy? So we talked about this bad protein. That's shown on this slide. So this is a normal, they take a drop of your serum, they put it on like a Jell-O plate, if you will, and then they run an electric current through it. And they call that a serum protein electrophoresis. And it separates the different proteins in your blood. The big one, which all the women know and none of the guys probably know about, this is albumin. And these are the other types of proteins. When someone has too much of an antibody they shouldn't make, they get a spike, and they can measure how much protein is in that spike. And that's what we follow when we determine how well you're responding to therapy, is if that spike gets lower and lower and lower, and hopefully it gets back down to the normal range. When we want to know what eye color you have, we do this test called an immunoelectrophoresis. And this just tells, the one I just showed you before tells you how much. This one tells you what color your eyes are, okay? So this is a yes or no, and this is important because when we tell you you're in complete remission, which I'm hoping that many of you are in complete remission, this test is important for defining complete remission, because when you're in complete remission, this test comes out negative. But it's a yes or no. This particular person has a glop here in G and K, so this is an IgG kappa. This is a different orientation, it's the same test. This person has a thing, these are the Greek letters, kappa and lambda. This particular person has a glop in the lambda. So we have these are two different people. One has an IgG kappa, one has a lambda. That's their eye color. So these are the bad guys. And as you can see, one of these bad guys is a double omelet, okay? Myeloma cells do not look the same, and they don't act the same. No one in here has the same myeloma. Everyone is individual. And each of your myeloma cells that you have can be different. This particular guy with the double omelet acts more aggressive than the other ones do. So the way they look sometimes tell the way they act. So all myeloma is not created equal, and they don't all look the same. So this is just to show you these guys. This one I should ask Ruben. Ruben, do you know where this is? Are you here? Where is he? He went out? Oh, that's too bad. This is, again, I'm not going to torture you. This is outside the Church of Guadalupe in Mexico City in the Zocalo area. And Ruben's from Mexico City, so that's too bad. This was his chance to shine. But these guys, they're all dancing, they're all dressed in their costumes, but they're all different, right? They all go to different homes, they all have different costumes. Every one of you is different, just like these guys are different, but they all are dancing, they're all wearing costumes. You all have myeloma, you all have different features of your myeloma, but you're all different. So we have a series of events that happens with myeloma. Everyone with myeloma goes through a long incubation period, and we don't usually catch that incubation period. Something happens later on that you end up being diagnosed much later. But myeloma evolves from a term called MGUS. And I've got a few more slides on MGUS in a second. MGUS is a benign problem. Your immune system just is a little bit off, and you make antibodies, and there's no infection. It's just a little bit off. This is very common as we old. Your knees give out, your back gives out, your hearts don't work as well, your kidneys don't work as well. Well, your immune system doesn't always work so well either anymore as when you get older. And when your immune system doesn't work so well, sometimes it makes antibodies that they shouldn't make. And this is a benign thing. It's sort of like a person, when you go to your doctor and he says, oh, I see a little mole on your hand, we're going to watch it. Well, that's what we do with MGUS. We watch it because it's a benign condition. It's very common. If you take all 50-year-olds in the country, about 3.5% of them have MGUS. A small percentage of those people will eventually develop myeloma, which we're going to talk about in the next couple of slides. So there's a precursor lesion, a benign lesion, that ultimately something else happens to those patients to develop myeloma that requires treatment, and that's shown on this scale. They go through MGUS to smoldering myeloma to myeloma that requires treatment. So a year ago, we got together, and it's called an International Myeloma Working Group. Last year it was in Milan. This year it's in Vienna. It's really hard to go to these meetings. They forced me to go. I really hate to go. This year it's in Vienna. Last year it was in Milan. And Milan, my highlight of that was not the meeting. The highlight was that you could actually go to the original Last Supper in a church there that was painted, I don't know, 800 years, 600, whoever knows the history of when it was actually painted. So at this meeting, though, we came up with a little bit different definitions of smoldering myeloma. So MGUS, this benign problem, like the mole on your hand that the doctor's watching, means you have less than 3 grams of this antibody protein, you have less than 10% of these plasma cells, and you don't have any symptoms. Smoldering myeloma is a condition where you make more than 3 grams of protein, you have more than 10% of these cells in your bone marrow, but you still don't have any symptoms, and we call that smoldering. This is only about 15% of the patients have smoldering myeloma. Do we have people in the audience who have smoldering myeloma? Yeah. We're going to talk a little bit more about that. So it's about 15% of the myeloma patients who have smoldering myeloma. In contrast, myeloma requiring treatment is anybody who has any amount of protein and any number of myeloma cells, but they have some kind of symptoms. The symptoms are shown at the bottom of the slide here. You have problems with your calcium, you have problems with your kidneys, you have problems with anemia, or you have problems with your bones. If you have any one of these and you have a protein or too many plasma cells, myeloma cells, you require treatment. There's a small group that we call slim myeloma. These were patients we used to classify as having smoldering myeloma. We're now calling them patients who require treatment. And this is a group, it's 15% of the 15%. So if you do the math, before everyone freaks out if you have smoldering myeloma in the audience, if you do the math, it amounts to about 600 patients in the US total have this thing that we call slim myeloma that have high-risk smoldering myeloma. And we've decided that those patients should require treatment, and I'm going to show you 2 slides on this, but it's if you have more than 60% plasma cells in your marrow, if your free light chain ratio is over 100, or if you have more than one spot on an MRI or a CT scan. Those patients don't have symptoms, but we consider them treatable now because their risk of developing symptoms is 80% by 2 years. So we have a new group called slim myeloma. This is MGUS. MGUS continues to increase over time. I told you it was 3.5% in 50-year-olds. It's almost 10% in 80-year-olds. So the risk of having MGUS, a benign problem, keeps going up. Males have it twice as often, or male-female ratio is the same, and what I didn't mention before is African Americans have myeloma twice as often as Caucasians, and they have MGUS twice as often as Caucasians. What happens to MGUS? On the bottom line here, this is the risk of MGUS. There's a 1% risk a year of developing myeloma if you have MGUS. So if you're 70 years old and you go to the doctor and he says, oh, you've got MGUS, if you live to be 90, you have a 20% chance of developing myeloma. That means 80% chance you're not. So there's very slow risk increase for patients with MGUS. It's 1% a year, cumulative. What about smoldering myeloma, the group that meet the criteria for myeloma based on their protein and their plasma cells, but they don't have any symptoms? Well, that's shown in this curve, and the smoldering myeloma risk is about 10 to 15% a year, not 1%. And I'm going to show you another slide on that in a second. So things really kind of move slow. Anyone know where this is? Galapagos, yeah. Yeah, things move slow. These are not turtles, they're land tortoises. Don't, otherwise they yell at you. So there's different types of MGUS. Not all MGUS is created equal. It's 1%, but there's some individuals who have higher risk MGUS. This is something your doctors know to follow based on your laboratory findings. Smoldering myeloma, we already talked about, no symptoms. It's about 15%. And we talked briefly about slim myeloma, the high-risk group who we now put into the treatable myeloma category. So smoldering myeloma, because we have a handful of people with smoldering myeloma, is shown on this slide. If you look at the group, and you can divide this out based on risk factors. And what you can find here, if you have actually fairly low risk factors, the risk of developing myeloma even at 10 years is 50%. But that means at 10 years, there's still a 50% chance you didn't get myeloma. Even if you have high-risk myeloma, there's about 15%, or high-risk smoldering myeloma. There's a 15% you're never going to have symptoms. So smoldering myelomas, except for this slim myeloma group, don't really require treatment. There are clinical trials sometimes for these patients to try to prevent them from developing symptomatic myeloma, which I don't know if one of my colleagues is going to talk about this or not. So this is what we think happens. You have MGUS, there's something wrong with the immune system, which is the left-hand panel. There is some other event that happens, and the cells change. So you start off with this cell here, this is a normal cell, something happens to it, and it starts doing something weird, but it's not a malignancy. But then it changes, and you get different things over here in smoldering myeloma. And then there's even more changes genetically, and you have myeloma that requires treatment. So this is a very slow process. This is an evolution, which is why I'm showing you the Galapagos Island pictures. This is an evolution of changes over time. And this is one of the catchphrases in myeloma. It's called clonal evolution and clonal competition. And I don't want to confuse you on how to interpret this slide. All I'll tell you is that myeloma is not one clone. When I was taught, we used to say myeloma is one clone, one cell, causes all this. Myeloma is probably 8 or 10 different clones at any given time. What do I mean by this? Let me explain. So this is somebody who gets diagnosed with myeloma, and let's just follow his orange color. So 72% of the cells are this orange color. He gets treated with lenalidomide, Revlimid, dexamethasone. The orange color gets lower, gets more Revlimid, dexamethasone. The orange color gets very, very low. The person's in remission. What are these other colors? These are other clones of myeloma. First there's a, whatever this is, chartreuse color, and then there's a blue color. So here a different clone arise, so the patient got treated with carfilzomib, Kyprolis, and to see if they can get rid of the blue one. And sure enough, the blue one got better, but then this greenish chartreuse color came up. What happens to that? So we treated this patient with a study drug, and we treated that one, and look, sure enough, the original cell started growing again. These things keep changing and changing over time, and ultimately you get clones that didn't even exist back here. A whole new clone has arisen. So the disease keeps changing. It's a moving target. And each time a target changes, we have to come up with a different treatment, which is why it's so difficult to control the disease. How do I know this is true? This is data that was published by the Mayo Clinic. This is somebody's chromosomes. You know, when you guys were all in biology class, they had chromosomes, you may or may not have cut out the 23 pairs of chromosomes. You know, men have XY for chromosome 23, and women have XX. So this is a chromosome pattern, which is labeled across the top here. So the blue means you had extra chromosomes, and the pinkish color means that you lost chromosomes. This is one patient. And when you look what happens here, this is a diagnosis. There's almost no deletions, the pink ones. There's a bunch of additions. And then they have their first disease relapse. There's less blue, there's more pink. Second relapse, there's even less blue. And down here, it's all kinds of things. This is the same patient's myeloma changing over time every time the patient relapsed. So what are the clinical manifestations? I'm not going to spend a lot of time on this. Most of you know this. You can have problems with your kidneys because the myeloma proteins can clog your kidneys. You can have problems from your kidneys because you have high calcium. You can have problems with your kidneys because you can have amyloid, which is a concomitant disease. All these things can cause kidney problems. About 20 to 30% of people have kidney problems. Bone disease is the most devastating. 85% of you will have bone problems. The bone problems are not a direct cause for myeloma. And briefly, I want to explain bone and anemia. But in the bone problems, our bones are being remodeled all the time. Doesn't matter if you have myeloma or not, our bones are always being remodeled. There's a cell called there's a Pac-Man type cell. Most of you, if you remember a Pac-Man, little thing that goes and eats things, that's called an osteoclast. And there's another that eats bone. There's another cell called osteoblasts that make bone. Normally they're in synergy with each other, that they equal each other, the osteoblasts and the osteoclasts. Myeloma has a network. AT&T calls up the Pac-Man cells and tells them to overeat bone. When they overeat bone, they cause holes. So if you have too much bone being eaten, you get calcium release. Calcium can cause all kinds of problems if it's too high, including problems with your kidneys. Same thing's true with anemia. 75% of you will have anemia. It's not because your bone marrow is packed with myeloma. It's because they use a sprint line. The myeloma cells use a sprint line and tell the red cells not to grow, and you become anemic. So you have to cut those lines so your bones heal and so you don't become anemic anymore. Diagnosing myeloma. There's routine blood tests. We already went over the protein electrophoresis and immunoelectrophoresis. Most people need the urine. There's a test called the free light chain assay, which is to measure the free light chains, which is that part of the immunoglobulin or antibody molecule. Bone disease, you need x-rays of your bones. Everyone continues to get skeletal surveys. The biggest issue and the most common presenting symptom for people with bone disease is compression fractures of their back. And that's because, A, our bones start to leach calcium as we get older. The women in the room that are postmenopausal know about this more than the men do. You get osteopenia or osteoporosis, and you should be on vitamin D and calcium. So the bones get weak just from aging. And then if there's holes in them, it's like having Swiss cheese and a weight putting on you, the weight being gravity, pushing on your back. And if you have Swiss cheese and washed out bones and gravity, you get compression fractures. Well, this is not a back, this is an arm, just to show you what a hole looks like. This is somebody who's got a huge hole in his arm. There's one here, and this whole area is missing bone. So if you look at this, this is just the outside. We call this the cortex. This person, which I actually have the subsequent picture showing a fracture. I don't want to gross anyone out. But this person sneezes or coughs, and that bone's going to break. It's a big hole from Pac-Man cells. It's not myeloma cells in that hole. That hole is permanent. Even if it breaks, it can heal on the outside, if you will, but it doesn't heal on the inside. This is a tough one. I'm not going to torture anyone. This is one of the coolest places I've ever been. This is a salt mine outside of Krakow, Poland. This is like 1,500 feet underground. The miners built a temple, a church, 1,500 feet underground. This is completely salt. This is all salt. What you can't see here, it goes around. These are the 12 stations of Christ shown on the outside here. This is the altar over here. Everything here is salt except for the wood that's holding up and the light bulbs. The light fixtures are all salt as well except for the bulbs. Different tests can give you different information. Regular x-rays are really not very good. This is a backbone that's squashed. You can see the same backbone squashed here with MRIs. CT scans show it, and PET scans can show it. These tests depend on your doctor and what symptoms you may have, whether you should have any or all of these tests. It's really individualized whether you should have these tests done. Whether you like it or not, you need bone marrows done. This is where the guys live. And we have to do the bone marrows. It's necessary. So once we have the diagnosis, you have myeloma, the next question, which we raised before, is how bad is it? Well, we have a staging system. Stages 1, 2, and 3, 1 being the least amount of myeloma, stage 3 being the most serious stage of the disease. It's based on tests that can be done anywhere in the world. Beta-2 microglobulin is one of the tests. It's on the surface of the myeloma cells, and albumin is a measure of which is a measure of how much myeloma you have. Albumin is a measure of how active the myeloma is. So these tests put you in a staging category that can be done anywhere. The French, in particular, the French in the Arkansas group, have done a lot of genetic workup in myeloma. This is on top of Notre Dame, the gargoyles. And there's been a whole series of genetic testing that's been done, and this COMPASS trial, which has been alluded to before, is very, very important because it's going to combine all these modalities in the patients who are enrolled in the COMPASS trial. And I know Mount Sinai, I think Mount Sinai is the highest accruer, and I think we're number 2 or 3 in Hackensack. So this is to get a better feel for the genetic makeup of your myeloma. This is a variety of tests that have evolved over time to become more and more sensitive to help predict what is actually going on in your myeloma. And this is the COMPASS trial. They're looking for 1,000 patients. They're up to 900. This is a sequential trial of 5 years duration where we're doing all these genetic tests at the time of diagnosis and when you relapse, so we can understand the biology of what happens to that myeloma over time. I showed you this clonal evolution. We're trying to get down to the genetic makeup of clonal evolution. Hopefully we can take that information and design specific drugs for individual patients based on this information. That's the ultimate goal. And this is what we need. This is the Rosetta Stone. We need something to interpret these tests, which is exactly what happened with the Rosetta Stone. It set the world afire, and these tests are going to be our Rosetta Stone because it's going to help us interpret your myeloma. There is a classification based on risk, on genetic makeup of your myeloma that we call high, intermediate, and standard risk. And this up on the top, you see what the likelihood of having any one of these categories may be. I don't want to talk about the outcomes with this group of categorization, but high risk is obviously worse than having intermediate or standard risk. So we can actually have a better feel for what's going to happen to you long term based on the risk stratification on your genetic makeup in your bone marrow. You have to have the bone marrows. Very, very quickly, treatment overview, and I think I've got more slides in there that I'm going to talk about because I'm going to finish. MGUS, we don't do anything. Depending on your numbers, we decide how often you need to be followed. Some of my patients I only follow every 1 to 2 years with their MGUS. Some patients with MGUS I see every 6 months. It really depends what their numbers are. Smoldering myeloma are the ones that don't have symptoms. It's 10 to 15% likelihood. If you look at the whole group of developing myeloma, we generally follow those patients every 3 months or so. And active myeloma gets followed much more closely and are treated with chemotherapy. A small fraction of the smoldering myeloma may be eligible for a clinical trial. Briefly, before treatment, to set up my colleagues, in 1844, Sarah Newberry, our 39-year-old, she was treated with rhubarb and infusions of orange peel. Don't think it helped much. Maintenance therapy, which I'm hoping that Dr. Girault will talk about later on today about maintenance, and for those of you who have transplant, you may be on Revlimid maintenance therapy. First maintenance therapy was actually phlebotomy by leeches. So in 1845, this is what they put them on, the maintenance therapy with leeches. In 1947, they thought urethane, which I'm going to show you slides in a second. Urethane is in floor hardeners and plastics. There was a paper with something like 10 or 12 patients, and 3 or 4 of them responded to urethane. And they thought this was a good drug for myeloma in 1947. We'll see more about that in a second. It wasn't actually until 1962 when melphalan was first described and published by Danny Bergsagel, as also in the same year, prednisone, the hated steroids, was first described as having activity in myeloma. Melphalan, for those of you who have had transplants, that's the drug we use for transplant, first described in 1962, it's a long time ago. So some of the old treatments, we learned from them and try to make things better. So this is a slide that I borrowed from Ruben, who apparently is still out, so I'm going to steal his thunder. I know he's not showing it, but this is actually Ruben's slides. So in 1966, in a very important journal called Blood, which is still one of the premier journals for hematology research, they published a trial. So I already told you in 1947 they thought urethane, this floor hardeners and plastic stuff, killed myeloma. So the proper way to evaluate a drug to see if it works is to compare it with something else. So in today's world, which I'm sure Dr. Cho is going to talk about later when he talks about investigational therapies, we don't give placebos to patients with cancer unless we give them an active drug. So none of you get placebos if you have cancer. You may get drug plus placebo to see what happens, but no one will get a placebo itself. But back then they did. So they used urethane, which they thought worked, and they compared it to placebo. The placebo was Coke syrup. And they treated 80-some patients with Coke syrup versus this urethane. And you may or may not see more slides like this from my colleagues later, but whenever you see a slide like this, the line on the top does the best. So if any of my colleagues show you slides with a bunch of lines on it, the one on top is the best group. Well, the best group in this slide was the Coke syrup. So what does this tell you? A, urethane is probably not a good drug. B, if we didn't have a clinical trial, we'd still be using drugs like urethane. Hint, hint to the audience members. If you don't participate in clinical trials, we're still going to be giving you urethane. I don't think that's what you want, right? So this is my plug for clinical trials. So in summary, we have myeloma causes a whole variety of effects on the body. Our wave of the future is genomics. This COMPASS trial, which is sponsored by the MMRF, is essential for our understanding of your myeloma, your individual myeloma, not myeloma per se, your individual myeloma. So we can personalize your treatments and give you drugs that work for you. Survival has improved drastically. You already heard before that the survival rate's gone up 40% in a few years. I'm expecting, and my colleagues are going to talk about this, we had just had a drug approved in February. I think we're going to have 2 more drugs approved by a year from now. We've got all kinds of drugs. They're targeted drugs. They don't have anywhere near the side effects of other chemotherapy drugs, which you're going to hear about. And this is going to improve your survival. When I first started doing myeloma, when I joined Sundar in Arkansas in 1990, the average survival was 2.5 years. The average survival now is over 10 years because of the drugs that we've developed. And this is a shifting paradigm to personalized medicine. And with that, I'm going to take questions. Thank you.
I'm just here because Dr. Jagannath had to leave, so I cannot speak as quickly or with his accent or the outrageous comments. But I'm here on his behalf, and this forum is for you, so we really encourage all of you to ask your questions. There's no one there.
Hi, you said 75% of us will suffer with anemia. How do you treat that?
For which again, I'm sorry?
75% will develop anemia, is what you
Anemia?
said.
So,
Anemia.
anemia is...
But you didn't mention anything about treatment for the anemia.
I'm not going to talk about treatment at all. My esteemed colleagues are. But basically, the concept I will explain, not the exact treatment. So A, you have to kill the myeloma, then you cut off the sprint line so you don't have suppression of the red blood cells. Or B, you can bypass it by giving drugs that stimulate the red cells to grow. The ones that you're aware of are Epigen, Procrit, and Aranesp. So A, you have to cut off kill the myeloma cells so you have no more sprint line to telling them not to grow, or you can bypass that by giving drugs that actually stimulate the red cells to grow.
There was another question over there.
Is a patient whose only cancer experience is if they have multiple myeloma, is that patient down the road more likely, less likely, or no correlation to develop or be diagnosed with a more traditional tumor type, cancer, lung, breast, colon, et cetera?
That's a great question. So what's the risk of getting a second cancer is what you're asking about. So unfortunately,
Non-blood cancer.
I don't mean to alarm anyone. I'm just giving you the facts. Individuals that have one cancer have an increased likelihood of getting a second cancer. That risk is about 2 to 3% that you'll get another cancer just because you already have one. Regardless of what the treatment may be, there's a little bit higher risk of getting a second cancer if you have one cancer. But it's not overwhelming. It's less than 5% that you have a risk of getting some other cancer completely unrelated.
There's a question.
How do we join this study that you are doing?
The COMPASS study? The COMPASS study is for patients who are newly diagnosed that haven't had any treatment. So this is something that, and most of, I can't speak for the other centers here, but it was for patients newly diagnosed with any treatment because you want to get a baseline to know what their myeloma looked like before you started changing it with the drugs that you gave them. So if you've already been treated, you're not a candidate to participate in that COMPASS trial.
Earlier, you spoke of clonal competition, and you showed the changes via colors that the cancerous cell went through. Does the color, excuse me, is the color indicative of anything other than the change in cell? Does it have any special meaning for the person with the cancer? Was it more severe, or is the only difference that he or she has to take a different medication?
So that's a difficult question to answer, and you probably won't like the answer I give you either. What happens is over time, when those cells keep mutating and mutating and mutating, sometimes they don't act the same anymore. They become more aggressive the more they mutate over time. They're getting more unstable genetically, and those unstable cells can act more aggressive. So whereas you may have never had problems with calcium before, now when they become more aggressive, they may cause your calcium to go up. Or myeloma in general doesn't cause masses of disease. And sometimes when they become more aggressive, they form masses of myeloma cells that we call plasmacytomas. So over time, with all the genetic shifting and evolution that goes on, the disease sometimes does change flavor.
Thank you.
I just had a question in reference to patients that are non-secretory. What tests would be the best to follow their disease, and are there any clinical trials that they would be eligible for?
So non-secretory myeloma, for those in the audience who going like, what does that mean? So 99% of you in the audience make a protein that we can measure, 99%. There's 1% that have myeloma that they don't make an antibody. So those are rare, rare birds. And yes, they do exist, and there may be people in the audience, a few people, given the number we have here. We may have a couple in the audience who have non-secretory myeloma. Traditionally, the way you follow non-secretory myeloma is by repeating bone marrows all the time, which I'm sure all of you would love to have done. But more recently, most of us will follow some type of radiographic evaluation, because most of the patients with non-secretory myeloma, well, if 85% of myeloma patients have bone lesions, you can follow them with serial CT scans or MRIs or PET scans in addition to their bone marrows. I often, in my non-secretory patients, I alternate their radiographic evaluation with a bone marrow every 6 months, which means a bone marrow twice a year for those who like to do math. But even that's much. But they're rare birds, but they're difficult to follow because there's no protein that's easily accessible.
Do the cytogenetics change over time? And with it, the risk assessment for the disease? And secondly, if we have the full genome sequence, do we know what to do with it?
I didn't catch that.
Does the cytogenetics change over time with the genomic profile?
Yeah, the cytogenetics, as I showed you, does change over time. It evolves, and they have more cytogenetic abnormalities with time. Doesn't mean it may be your first relapse or your second relapse, but over time, most of the patients, which is what they're following with this COMPASS trial, the genetic changes will continue over time. And I showed you the 23 chromosome things. You saw the genetic changes over time right before your eyes.
Maybe I can just follow up on that. This morning there was a caregiver question about that, which is how important do you think it is for a patient and a physician to know the patient's molecular pattern at different time points in their disease course? Because that was.
So that's a great question. Then I'm going to defer to my colleagues who are going to talk about treatment. There is an answer to that question. I'm going to defer to the people who are talking about treatment, about what you do with high-risk myeloma patients with genetic abnormalities.
I'm not sure if this might be a question for treatment, but does the age of a patient at diagnosis dictate the type of treatment they will have, or is it the stage that they're in? My mother was just diagnosed with this, and she's 83 years young. So if she was 53 years young, would that change the course?
So let's be honest, older people don't tolerate drugs as well as younger people.
Mm-hmm.
That being said, the treatments that we have for this disease can be applied to any age group, and the studies have shown that they can be safely administered. They may need to be modified, but
Okay.
all the drugs that we use for a 53-year-old are the same kind of drugs we can use for an 83-year-old, but with a little bit of a gentle approach. The only treatment that is not applicable probably to an 83-year-old is we don't do stem cell transplants in 83-year-olds, whereas a 53-year-old would get a stem cell transplant if they so elected, which somebody else is going to talk about today. So the issue with why older people are actually living, if you look proportionally, I took it out of my slide set. I don't know if I still have it in here or not. This slide actually answers your question better than what I just spoke to you about. This is a slide showing differences in 5-year survival over time. And if you look at the group that's the greater than 65, in 2001 to 2005, only a third of the patients were living 5 years if you're over 65. Then look at the group from 2006 to 2010. 60% of the patients are living 5 years or longer. They almost doubled the survival in the more mature group because we realized we could treat them successfully with the drugs that are available that we use with the younger patients. You have to also keep in mind that 56% is from 2005 to 2010. We're in 2015 the last time I checked. That number is going to be way higher than that. So the group that's getting the biggest bang for the buck and improving in their survival is actually the more mature group, because we know we can treat them safely with these drugs.
How do you differentiate between the Waldenstrom syndrome and multiple myeloma? What diagnostic tests are done to determine which a patient has?
Waldenstrom's is a completely different disease. The only similarity between the two is Waldenstrom's is a lymphoma that makes a protein, an antibody, and that's where the similarity is that they make an antibody, myeloma patients make an antibody. They're otherwise completely different diseases. And the type of antibody that Waldenstrom's patients make is an IgM, which is extraordinarily rarely seen in patients with myeloma. this is not a difficult diagnosis to differentiate between.
I think one final question before we.
Okay, I always learned that mutations were a very slow process and they happen very slowly. Does it happen that the myeloma induces mutations, or are these mutations kind of in the person anyway and kind of floating around, controlled by the immune system? And when we have a remission, does that mean after these drugs drive the cancer down, does that mean the immune system itself is actually, if you have a 5-year remission, does that mean the immune system itself is controlling the myeloma?
Immune systems in myeloma patients, even when they're in complete remission for long periods of time, usually are not quite intact. Your immune system obviously failed at some point in time, or you wouldn't have the disease to begin with. The disease does change over time. How fast it changes is based on the biology of every individual's myeloma. Some of them mutate very, very, very slowly or not at all, and patients pass from other things not related to myeloma. Other people have more aggressive forms of myeloma, which you can usually predict from their initial evaluations. So everyone's different to answer that question.
So there's no
but
kind of general...
the immune system is really not cutting it.
So what actually accounts for the remission?
Because we kill the cells, the majority of the cells. We don't kill all the cells, unfortunately. Myeloma, most drugs, even when they're targeted therapies, in general kill cells that are active. And myeloma cells are very, very, very slow growing. And most of the drugs we use kill cells that are alive and doing something. So if the myeloma cells are asleep, they sleep through the therapies, and then they eventually wake up, they staggered over time.
So on that, many thanks to Dr. David Diesel for his presentation.